Dr. Shalini Kumari. If the presentation is ready, the second speaker.
Good morning. My topic is benign eyelid lesions and its histopathological picture, a case series. A wide spectrum of lesions can arise from eyelid lesion as various skin appendages are present in it. Both benign and malignant tumors can originate from any of these eyelid layers. Although it is known that majority of eyelid lesions are benign, yet ideally all clinically benign appearing eyelid lesions should undergo histopathological analysis to rule out malignancy. Thorough knowledge of clinical features and subsequent confirmation with HP aids in early detection of tumors, more so in masquerade syndromes, and also in reinforcing an ophthalmologist clinical diagnostic opinion. The purpose of this case series was to evaluate the clinical features, HP picture, and treatment of benign eyelid lesions in a tertiary referral setting. The design was prospective case series. First 9 patients referred to the author with unilateral eyelid lesion in the month of 2024 April was taken up. Main outcome measures I have already mentioned. Coming to results part, benign eyelid lesion in our case series were epidermal inclusion cyst, giant conjunctival inclusion cyst, epidermoid cyst, dermoid cyst, intradermal nevus, dermal nevus, apocrine hydrocystoma, capillary hemangioma, and lobular capillary hemangioma. So my first case was epidermal inclusion cyst. It usually presents as a smooth, round or oval domes epidermoid. In our case, it was excised, followed by eyelid reconstruction by Tengel's semicircular flap method. The second case was a giant conjunctival inclusion cyst in a young 4-year-old child, which is an uncommon adnexal lesion in children. It was causing mechanical ptosis. It was excised entirely by a modified noose technique. Our third case was an epidermoid cyst. Epidermoid or dermoid cyst is the most common cystic orbital lesion seen in children. It's a choriostoma. In toto excision of cyst using lead crease incision approach was used in our case. Third case was a dermoid cyst. Dermoid cyst clinically appears as an eyelid tumor, has contiguous extension of an orbital lesion. Again, in this case, in toto excision was done using lead crease incision approach. Our fifth case was an intradermal nevus. A type of intradermal nevus, it presents as a homogeneous globular pattern. The intradermal nevus, most benign type of nevus, is sometimes known to transform to melanoma, very rarely. So this acquired type of nevus again underwent save excision with no recurrence so far. Our sixth case was a dermal nevus. Nevus of eyelid is characterized as a common benign melanocytic lesion. In our case, again it underwent save excision with no recurrence so far. Our seventh case is a case of apocrine hydrocystoma. It's a retention cyst. It is located at eyelid margin in adults. A blocked excretory duct of Gauss gland is its origin. Marsupialization of cyst was done. Our eighth case was actually a capillary hemangioma, which is the most common benign vascular tumor of eyelid in childhood. It's a congenital hematomous lesion. Our case was a superficial variant localized to epidermis and dermis. And since it was amenable to excision with meticulous hemostasis, the lesion was transected utilizing electrocautery. Our ninth case was a lobular capillary hemangioma, which is a common vascular lesion of skin and mucous membrane in infancy and childhood. There were history of episodic bleedings in our case. It was treated with tangential excision and cautery. So coming to discussion part, in our case series, all 9 cases were of benign origin. Nevus 2 in number was the most common benign lesion in our series. Again, the histopathological diagnosis of 8 lesions were consistent with their respective clinical diagnosis, while 1 lesion, epidermal inclusion cyst, was misdiagnosed by us. While a large study conducted by Constant et al. Reveals 13 cases to be malignant and 3 to be pre-malignant on HP examination out of pre-thought total 692 benign lesions. In our cases, all cases underwent surgical intervention. No cases showed any recurrence during follow-up. So coming to conclusion part, thorough knowledge of clinical features of all eyelid lesions and subsequent confirmation with HP examination of excised tissue is a must, as it is not possible to obtain 100% accuracy in diagnosing eyelid lesions on clinical grounds only. These are my first 5 references. Thank you.
Thank you, Dr. Shalini. It was a nice presentation, complete set of pictures, each patient you have shown very nicely. Just one question, in case number 1 and 2, you said that you did tensils, and in the case 2, you said you did Hughes. So I was wondering, in benign lesion, generally we don't do full thickness, removal of the eyelid. and go ahead with this kind of thing. So what was your
Ma'am,
case, why it was done? So,
Ma'am, in the first case, since I have been attending and discussing it with my colleagues and seniors, so they say through lead cage incision, the epidermal inclusion cyst, it can be taken out. But it was my first case. First, I reconstructed it. It was actually went into resurgery, with the direct approach, and since it was more than half, almost half, that was a misdiagnosed one. So ultimately, I have to do the resurgery with tangles flap. I know that it can be done through lead increase.
yeah, only the cyst removal
Yes,
is
yes, I
required.
can.
And similarly, in the second case, you just have to go ahead with the cyst removal. You don't have to raise any flap or do any
No,
additional.
it was a noose technique. Just reversed it. It was a huge one, and
But generally, that is also not required. So I was wondering, because generally these cysts you can just give a cut in the conjunctiva or skin, and you can just take it out, and rest of the tissues you have to leave as it is. So augmentation generally is not required until unless you are taking out with the conjunctiva for some reason.
No.
Then you might have to put a graft or a flap over there.
Underside the conjunctiva only I dissected. I thought that I'll end up puncturing it. So what I did was just applied a noose and then pulled it. I have a video also, but of course I can't show it. And then took it out so that it's taken out in toto and there is no recurrence.
No,
That
that is
was the
fine,
only
but why
thing.
Hughes procedure? That is my question.
I had I was going
Some
through the
defect was
literature.
there, some
They said
conjunctival.
that cysts
Acha,
can
okay.
be taken out with the noose technique better without
Okay,
that.
okay.
That was the only purpose. Nothing else.
Okay, okay.
Thank
Thank you.